Why am I here from Broward County? Well, a couple of months ago I was on a similar panel down in Broward County. Attended. The theme of the hour of the panel that I was on was ACOs and CINs, what works and what doesn't work. Kenneth thought it might be a good idea for me to tell you what we thought in Holy Cross Physician Partners, which is our accountable care organization, since we have some experience and some track record about actually what works in these models and what doesn't work. So that's what I hope to give you in the next 10 minutes. Holy Cross Physician Partners is part of Holy Cross Hospital, which is in eastern central Broward County. Holy Cross Hospital does own Holy Cross Physician Partners, so we, unlike some physician-owned and only physician-run ACOs, we are aligned with the hospital, and we think there are some good reasons why we've done that. I think both systems work, and only time will tell, but certainly our system early on has worked by being aligned with the hospital. So we are a group of 300 plus physicians. 174 physicians out of those, a little over 300, are employed by Holy Cross Hospital and the Holy Cross Medical Group, which has both primary care physicians and subspecialists. We have aligned with 128 other independent physicians to form our network. We're growing all the time. We're concentrating primarily on primary care physicians, which I'll explain to you why in a few minutes. The hospital is there, right near the ocean, in central eastern Broward County. The blue line is our service area. The Holy Cross Healthplex, which is where our Orthopedic Institute and Women's Center is close to the hospital. The blue circles that you see are our employed medical group. We are not all in one place. We are all over Broward County, as you can see, primarily in eastern Broward County. But our goal was to widen our service area with our clinically integrated network so we could take care of as many patients as we could. And we've been able to do that before. Actually, the red is our ambulatory care centers. One is in South Broward County. A second has recently gone up on in southern Boca, right on the border of Broward County and Palm Beach County on Federal Highway in southern Boca. That opened a couple of weeks ago. And then the orange dots are our aligned physicians in the network who are independent. And as you can see, we have many independent and aligned physicians both on the eastern side and western side of Broward County, as well as in Boca Raton, where we have some of our employed physicians, as well as now many aligned physicians in Holy Cross Physician Partners, our accountable care organization. This is a slide that you could say Jim Goldenberg and I probably put together. It's where his was today and yesterday and today. Mine looks prettier, but otherwise it's the same. It's the same slide. It talks about the change from volume to value, as Jeff Goldsmith also this morning talked about. Things are changing to value-based medicine, accountability. We are now becoming, as physicians, as health systems, accountable for the care of our patients. There's a reason it's called accountable care. We are now being judged, basically, and being told we have to prove outcomes. We have to close care gaps. You can call them metrics in insurance language and in MSSP language or HEDIS language are called metrics. I like to call them care gaps, opportunity gaps. We have to show that we're fulfilling opportunities to take better care of our patients. And that's how reimbursements are going to be, and they're starting to be here already and will be more in the future. The bottom line is that's good for the patients, and whatever we do, and as an internist, it's all about quality of care of the patients and patient safety. I think you've heard that all throughout today. All of this is really how do we take better care of our patients, because if we're not doing that, then none of this really makes any sense. It's all about taking care of our patients. And the change from volume to value, at least people, myself and others, who believe in population health, in value-based medicine is better care for our patients because now we're more accountable for their care. Whether it's physicians, hospitals, home health companies, nursing homes, the whole system now has to be accountable for how well we take care of our patients. It's a change from fee-for-service to whether it's bundled payments, as Jeff Goldsmith said this morning, or capitated payments, but it's a change, a slow change, although we do think, I think fee-for-service will never go away, it's just not going to be as important. It's a whole culture change, and we talked about culture change all day, from treating sick people to keeping people well. It's not treating acute illnesses, which is a huge cost to our system, but it's implementing preventative health measures and changing doctors' offices, especially primary care doctors' offices, but also specialty offices, to keep our patients well, not to treat their acute illnesses when they walk in the door or walk in the hospital. So we took a different route at Holy Cross Physician Partners in Broward County. Most ACOs start with a Medicare shared savings product or Pioneer Medicare product. Whether we did the right thing in terms of starting with commercial insurance companies and Medicare Advantage companies, only time will tell. It has been successful for us in the few years that we've been in existence. We will be signing a Medicare shared savings. We did apply for Medicare shared savings and hope to see our first patients for Medicare shared savings this coming January 1st. But we actually signed and joined hands with, as much as we could, with third-party payers, including Florida Blue, Cigna, and soon to be Aetna, and a Medicare Advantage program also with Florida Blue. And I'm going to tell you a little bit about our experience and what worked and what didn't for those plans. So we have attributed patients who we already take care of that have those insurances that have rolled basically into our accountable care organization by virtue of the fact that our primary care doctors take care of them, or new patients that have that insurance that come see us during the tenure of our plan. We have about 16 or 17,000 patients. By January 1st, we'll have over 35,000 patients attributed to us through all these plans. And the idea, just like Medicare shared savings, all these plans are similar. If you can be accountable for the care of your patients and close care gaps, or if you want to call them metrics, and be able to save money for the system, do it efficiently by a lot of things I'm going to talk about in the next 2 or 3 minutes, hopefully, and save money for the system, you will get part of that savings back to run the infrastructure of your ACO and to reimburse the systems that you're working with, in our particular case, the physicians. So this is the data that the insurance companies look at, and that we're starting to go out to employers to show them as well, to see if they're interested in joining with us for their employees. And these are the care gaps we started with Florida Blue in 2013 as an example. We have 6 of them there. The gold is our peer group for the year of 2013. There are 3 preventative health metrics and 3 diabetes metrics. We started slow. You'll see in a minute we have a lot more metrics and care gaps that we're following. The peer group is gold, and Holy Cross Physician Partners is in purple. So you can see that in every opportunity that we had to close a care gap, we were better than our peer group, which was what our goal was. The last column on the right is the total, the composite. We were 6% higher in the total care gap closure over our peer group, which was the best in the state for Florida Blue. So if you can close those care gaps by aligning your physicians and the health system better, and save the system money, you get some of the savings back. So the second part is saving the system some money. This is kind of a complicated slide, but the yellow is the key. The left is the prior period, and the right is when we had the shared savings agreement with Florida Blue and really promoted our physicians to close those care gaps. And you can see that we did have savings that we distributed back for infrastructure and back to our physicians by doing things such as lowering brand name use in pharmaceuticals when appropriate for patients and using more generics, like lowering hospitalizations that were unnecessary by doing things like working very hard on 30-day readmissions and transitions of care, things we knew that we had opportunities to improve patient care, because it always comes down to improving patient care, but also save the system money. So lessons learned in organizing our network. It needs to be physician-driven. You've heard that all through today. Totally agree with that. It has to be physician-driven. We are associated with the hospital, but all our physicians push the committees. They're on all of our major core committees that run the organization. The hospital has right of veto of the decisions we make, but we've partnered with the hospital, and they're aligned with us. It's all about alignment of all the different parts of the healthcare system. But it has to be physician-driven. Engage independent physicians, especially primary care, and as you saw on the orange dots, we've been able to do that to some extent, so although we're always striving to do that better and have more independent physicians with us, as well as the employed Holy Cross Medical Group. You need a flexible technology platform to include both the employed and independent physicians, so they all have different EMRs out there in their offices. We have a disease registry system, which I'll show you in a second, that's an internet-based, web-based system. You can just sign on with a password, and you can get the data you need as a physician to know what kind of care gaps need to be closed on your patients. So you don't need necessarily the same EMR. In the future, there'll be health insurance exchanges, which we're already working on in our organization. That's going to pull data from labs, hospitals, doctors' offices, claims data from insurance companies. Everything we need to help take better care of our patients will be in one place, and we don't all need to be on the same EMR as we thought we might need to be in the past. Tailor your organization agreements to MSSP because MSSP's rules are so complicated. We need a strong peer review, so we have a peer review committee who guides physicians. We not only educate the low performers, but we reward the high performers of our physicians and our partners. Population health. Focus on quality first and cost second. It's all about taking care of patients. Invest in population care managers. Very important. As for physician satisfaction, as the gentleman from the AMA said, we're trying not to make our physicians do more. We want you to take care of your patients. That's what you were trained to do. That's what we were all trained to do. Our goal is to make it easier for your offices and you to close up care gaps, to take better care of your patients by helping you organize with population health measures. And care managers, population care managers are the key to that. Concentrate on quality improvement in chronic disease states. Develop a high-risk tool, which we have to decide which patients or which subsets of patients we need to work on and improve their care, and do more preventative care. Concentrate on cost savings such as transitions of care, 30-day readmission rates. We're partnering with skilled nursing facilities. We have SNFists, just like intensivists and hospitalists, new words, new kinds of doctors. They're all part of our ACO. They're all working aligned with us. Those SNFists in the skilled nursing facilities are holding the skilled nursing facilities accountable for the care of our patients, working on pressure ulcers, infection rates, discharges from the skilled nursing facilities to the community, so we know we can let our primary care physicians know those patients have come out of the skilled nursing facilities, what's been wrong with them, what meds they're on, and getting them appointments with our primary care doctors, because a lot of them get lost in the system, whether they leave the hospital and go home or skilled nursing facilities and go home. We're working on all of those things. Not all at one time, but some are in the plan, some are already implemented down at Holy Cross Physician Partners. These are our population care managers. They're the key. They run the works. They talk to patients about closing care gaps. They talk to our doctors' offices about how they can help close care gaps. This is our disease registry, which is just a green light, red light on closing care gaps, so the doctors or their medical assistants, better yet, their offices and medical assistants can help them manage the patients better and know what care gaps need to be closed the same day the patient walks in the office. And last slide, payer partnerships. Developing primary care partnerships is the key. Fragmentation is really difficult in South Florida. There's not one major insurance company to work with that has a lot of patients attributed. In some areas, like in Massachusetts, for instance, where there's Blue Cross Blue Shield, you work with one insurance company, and there's lots of attributed patients. So we've had to align with many insurance companies. And also, we don't have like big groups other than maybe Holy Cross Physician Partners, where we have 174 employed physicians. Independent physicians are usually onesies, twosies. It's difficult to get a big group involved. I think I'm out of time. This is our quality care plan. Because we're working with different insurance companies, we now have over 100 quality care gaps or metrics. We're not just MSSP. We don't expect our physicians to pay attention to 106 or 120 quality care gaps, so we've narrowed it down to about the top 34 to work on, and we've kind of enabled the physicians in their offices to work on the ones that are important. And physician alignment, as I said, is the key. It helps to give early savings revenue to physicians, so we've had success in our first plan and have reimbursed our physicians, and that really drives engagement, obviously. But again, it's all about the patient, and the physicians are now realizing that if we can help organize their practices better, they actually have more time to take better care and spend more time with their patients as well. We've been an early adapter. That's helped. We had a low initial investment because we worked with the hospital who actually helped subsidize the startup of our organization, which can be extremely expensive. And as it's been echoed throughout, medical leadership involvement is really important, and we're still struggling with that. We're having the same problem in our county. I wish we had a great medical society like you guys do. Down in Broward County, we're working on strengthening that to get medical leaders. Thank you.